Okay, it's nice that they have like a little pop-up that.
Yeah, definitely.
Mm-hmm.
Okay, so my name is Kate Wegener, and I'm here with the wonderful Dr. Mitchell, who's graciously accepted my invitation to be interviewed as a part of this project. So thanks so much for joining me. I'd love to hear a little bit about yourself.
Sure. And thanks again, Kate, for inviting me to do this interview. I'm thrilled and more than happy to help out, and glad that you're in my class. I'm Lauren Mitchell. I'm currently an assistant professor in the communications department at the medical school, and the director of narrative medicine, which is a long-winded answer about what exactly that is. So we can talk about that another time. But basically, I'm part of a team of people that attempts to integrate the humanities and arts into communications practice for medical students.
Amazing. So a lot of today's discussion, I hope to center around an article that we read in class and that I sent to you that talks about health inequities arising and becoming more prominent and emphasized during the COVID pandemic. A main part of the argument that the paper made was that these health inequities and health inequalities were always kind of present and reflective of poor design of the US health and healthcare system. So that's kind of the direction that we're going with this. So my first question for you would be if you could please describe your work, especially as it relates to healthcare and interacting with kind of a variety of patient populations.
Sure. So right now, I've defected to academia, which has limited my interaction with direct care populations. I'm now working with students and helping them using some of my past experience to help guide them into responsible exchanges with their patients, especially because at the medical school, they get into clinic from their first year onward. Um, However, I still remain in some capacity or other involved in direct care. I have been what's called a doula since 2002, which is basically, it's typically associated, interestingly enough, with birth, and then there are also death doulas. I don't do that, but I admire their work. And a doula is a non-medical, emotional, informational, non-judgmental support person, often during birth. I'm part of an organization. I started an organization actually that opened up the doula model of care to reach out to people regardless of the outcomes of their pregnancies. So we provided care for choice, we provided care for miscarriage, stillbirth, and perinatal loss. As a footnote, my inadvertent specialty became stillbirth support for folks. And that's such a weird bureaucratic thing, honestly, amid all of the tragedy, that a lot of those patients end up falling in between these gaps and have to, I don't want to say go through it alone, but go through it not as supported as they should be. And then I've also supported births that have ended up in adoption plans a number of times. So all of that was with the spirit of meeting people where they're at and being able to shine a bright light in some dark places when folks needed it. And then I also used to manage one of the GYN specialty clinics at Bellevue Hospital in New York City. So those things are all kind of there. And Bellevue, being a large public hospital, got all of New York City's most complicated patients, and also stressful one. So sort of is the I don't know if you're frozen.
It seems to be cutting out for a minute. Let's see.
I'm here. I'm sorry I'm behind the black box for a second.
No, you're good. I think that seemed to help.
There we go.
I'm not sure if that was on my end or whatnot, but it seems to be fixed now.
Okay.
So my next question is, where have you seen health inequities come up as a relevant part of your work?
Sure. And I think I'll throw out there first that it's interesting to see how, on a state by state basis, it can vary so much. I'll try turning my camera back on. If I start freezing, I'll turn it off again. So New York City is, what I loved about working at Bellevue was that we were able to care for people regardless of what their financial circumstance was. That I think honestly may have been a little selfish on part of New York City, just with the knowledge that nobody wins when people are struggling on the street. Um, and people would often come to Bellevue to struggle, but it was great to be able to offer so much care. It's interesting because Bellevue is a public hospital, but it is also a public teaching hospital. And because of that, it's attached to NYU. Because of that, Bellevue is able to access, to be blunt, a really strong base of doctors that who they usually wouldn't be able to access because those were doctors being with an interest in academic medicine coming through NYU. If you compare that to some of the other public hospitals in New York City, like there's one in particular called Woodhull. I will gladly throw Woodhull under the bus whenever I can. They're such a problematic institution, and I can go into some of my experiences there as a healthcare provider, and also just, but they're just a public institution with no academic backing. So what I would see there, actually, that was frankly a little harrowing, is they didn't have very many resources. So patients, an easy example, they had 2 laparoscopy machines. Most surgeries are done laparoscopically because it's smaller incisions, safer, easier recovery. But when a hospital only has 2 of them, and I was working there for a time when a hurricane basically put Bellevue out for months, so we got reallocated there. Um, it was scary because ultimately it meant that if more than 2 patients needed a surgery, if somebody came in urgently through the ER with needing an appendectomy while 2 other surgeries were going on, or while the sterilizing guy, of which there was one, was on his lunch break, that person would have an open abdomen surgery when it could have been laparoscopic because they just didn't have the resources. So that was really scary. And that hospital is located in New York City is gentrifying beyond belief, but that hospital is located in one of the areas where it's still pretty poor, um, and pretty brown and pretty underserved. Interestingly enough, though, to vault forward, when I've done some doula work and practical care support in Tennessee, it was a whole different ballgame because at Bellevue, there were constant public resources. New York City's taxes are extremely high. Places like Texas and Tennessee don't have income tax, which means that you don't have any state-based resources. And watching patients who just didn't have any way of making things better for themselves struggle was really quite painful because, again, it doesn't have to be that way. And I understand that people don't want to see their taxes go up. And at the same time, I'm very humbled by the fact that, and this was like on Twitter or something, but we're all about a month away from being on the street. Not all, but many of us are a month, well, say 3 months away from being out on the street if you lose your job and can't get a new one. But none of us are really 3 months away from being a millionaire. You know, starting from the premise that we're all vulnerable, or we all have the potential to be vulnerable. And so helping one another be less vulnerable is ideally, it should be a community commitment, but I think people have trouble seeing that. Sorry if that was a little unwieldy.
No, that made a lot of sense. Lots of great points. Are there any health or healthcare institutions? We mentioned reflecting on hospitals and different hospital situations so far. Are there any health or healthcare institutions that you believe exacerbate or reflect health inequities more than others? Um, Four that were talked about in this article that were health institutions were the justice system, the meatpacking industry, hospitals, and elder care facilities. So it seems to me, I don't want to put words in your mouth, but it seems to me that you um, found that hospitals were healthcare institutions that exacerbated or reflected these inequities.
I believe that they do, hospitals do tend to reflect those inequities, but I feel like hospitals do it in kind of a roundabout way. In that, I don't think, um, I think hospitals reflect these healthcare inequalities in kind of a roundabout way where, it's all insurance based. So it's like if you're dealing, if you're at a hospital that mostly takes Medicaid, which is an unstable force in and of itself, it means that that hospital is just generally receiving less money, and you're not getting those doctors aren't getting the opportunity to train more or do anything else. So I do think that tends to be the case. And it's interesting because, like, now that I've been in Tennessee and now Texas, I'm seeing it a little bit. Interestingly enough, Texas has a little bit more to offer low income patients, which is heartening. Um, Tennessee, not so much. But I will sort of throw out another place that's not on your list, but homeless shelters. In that, I worked with, I'll share this anecdote. One of the last clients I worked with was a woman, I'll call her Q. Um, and I worked with her in about from March to July of 2019. And I started off being hooked into her care as a doula. She was pregnant with a baby who was diagnosed with trisomy 18, which is a very lethal genetic anomaly, and he didn't make it. So I was kind of hooked in originally to be that doula support, but I ended up mentoring her doula, and I was more there to with the practical support, because in addition to this pregnancy, Q had two small children who were both a year and a half. They were like a year and a half apart, and both, I think, under the age of 3.5. They were really little. And Q had left a very abusive partner. And she left when she was 7 months pregnant with these two kids. And I've just, she was a great example of somebody who the system is built to leave out. She had these, having toddlers is basically, we know it's hard, but like if you don't drive and you don't have stable housing and you're about to go through a surgery, because she had the baby by C-section, which is no joke, and you have these two little toddlers, it meant that there were a number of strangers who came together to help watch her kids while she was in the hospital and whatever else. I ended up staying close with her for a while. And, Q almost absolutely had some significant executive function disorder. Let me try this camera again. And not necessarily in a bad way. She also had one of the most brilliant philosophical minds I had ever encountered. But in terms of like laying down structure and to-do lists and keeping track of keeping things clean and the children groomed, that was just like a swirling chaos. And I'll be blunt and also say she is extraordinarily kind, um, but also has no filter. And she's a very big advocate of racial justice, but it meant that, especially in a place like Tennessee, which struggles with race, she would call people out on their racism in a way that was alienating. And I'm not faulting her for that, but she wouldn't, between the fact that she was so chaotic and the fact that she at times would really go off on people, often in a way that I think some of us would internally want to go off on people, but we wouldn't do that. She just would go. And so it meant that it was hard for her to find stable places because, you know, there was at least one homeless shelter that found a reason to ask her to leave, knowing that there would be absolutely nowhere else for her to go. And that was brutal. And we spoke about this other, we could call it like the St. Jude, like the homeless shelter that you go to at the time of all desperation. And she refused to go there and had some very good reasons for it, which was that basically it's a homeless shelter, but it behaves like a prison. You have to give your nail clippers over, you have to give your scissors over, you can't keep any of your own food, you have to be out at a certain time and come back in at a certain time. And it's dehumanizing. And it's interesting because it's like that is like a prison, the way that it would be mediated. um, and it made me think about what the message that we're sending folks who are very vulnerable is, you know. And obviously with COVID now, I shudder to think about how easily those places, it must have spread in places like that with people who have very unstable medical care at a baseline. Sorry. So
Based on your experience and what you just mentioned, would you describe it as predictable or unpredictable that COVID hit such minority groups the hardest?
I would err on the side of predictable, but in either case, it's unfortunate.
Yeah.
I think even when you look at the breakdown of essential workers, if you need to work at a grocery store because you have to feed your family, then yeah, of course you're at risk.
Yeah. How does that relate to that idea of biopolitics?
So through the structures that are available or not in government, so to per your request, so biopolitics is, in short, the sovereign ability to let live or make die. In other words, the government may passively allow people to survive, or they can go out of its way to execute them. But in either case, who gets to survive and how well is mediated through governmental structures. I think in the US, we see that it's mediated through the absence of these structures, you know. And because we are so monetarily driven, and I know that, and I'm sure, I think I've said this, and if I didn't, I'm sure it's obvious. Like, even as a person who errs on the leftist side of politics pretty far, I mean, we have to acknowledge that if we try to pull at the seams of our current financial capitalist everything, that it's not going to come down easily and it's going to be really hard. But in the meanwhile, folks who are like you, who can't work, who have two small children, who needs a roof over her head. Oh, and by the way, one of the kids was autistic. So just for that cherry in there,
Yeah.
who doesn't drive and lives in a southern city, it's like, it's not that there aren't solutions, but it's just that we're not looking at those people. And I think that we don't like to look at those people because of this belief that we want to believe we earned it. We want to believe that we're different. I think a lot of us view things empathetically, but there's a wall. And I think that wall is scary because we don't, I think it might force us to think about what we might give up in a way that feels uncomfortable, but is necessary. So I hope we can keep having those conversations.
Definitely. And thank you for bringing up those conversations in our class and in this interview as well. I'm curious, just in wrapping things up, if there's anything else you'd like to add along these lines of COVID induced chaos or biopolitics or anything in between.
I think that wraps it up well. I feel, I think the last note I might sort of mention is that I think it's kind of placed us as a society and a culture into a place of reckoning. And what I find so fascinating is that even with people whom I disagree with politically, um, it's not necessarily for lack of good heart. It's just that people are attached to certain core beliefs. But I think if you ask most people, like, does Q deserve a roof over her head? Like, what would you do to help her survive? I think most people would come up with the right answers. So I hope that we can figure out what healing looks like as we move forward, particularly as so many people are sick and dying from COVID.
That's huge.
Yeah. Yeah. Cool.
Awesome.
You're welcome to email me if you have any other follow-up questions or if you need me to clarify any of what I mentioned.
Thank you so much. Um, that was really perfect. Thank you so much. Let me stop recording.